after sitting here the last couple of days listening to all these lectures, and I start thinking about things and how they relate to what I'm presenting. And if you think about the development of any of us from conception to where we are now, there's so many variables that affect how you've become. You know, there's genetic factors, there's environmental factors, there's experiences that you've had, there's exposures to whatever you've seen, and it's amazing how any of us get to the point we are with all these variables. So it's sort of a very amazing process. And I think this is an interesting segue into the discussion of fetal origins of adult diseases, because as we develop, if you think about like circuitry or switches, as you develop, some switches go on, some switches go off, and ultimately they translate into the end product of who you are and who you're going to become. So pregnancy is just the first part of that journey. So we're going to review some of the concepts of fetal origins of adult disease, talk about some risk factors for the development of high blood pressure, diabetes, and discuss the role of the concept of epigenetics in shaping the outcome of the pregnancy and fetal and neonatal development. So really, parenthood begins at conception, because that's when you're creating the environment that the fetus is going to develop in, and that may have positive effects or it may have negative effects. Some of these you can control, some of them are out of your control. So this hypothesis suggests that adverse influences early in the development, especially in utero, can result in permanent changes in physiology and metabolism, which result in adulthood diseases. And this is all from the work of Dr. Barker, who noted that there were very high rates of infant mortality in England in the 20th century. And not only was he followed these people decades later, and they also had very high rates of mortality from cardiac disease. So he put the two together, that something happened maybe to these children early on that predisposed them to problems later in life. Some of the things that he looked at was low birth weight kids. So those who survived infancy might be at higher risk for cardiac disease later in life. When he looked at this again, there were two large studies of men born in England, and they showed a relationship between the cardiac disease with decreasing birth weight, head circumference, and ponderal indices, which is like a combination of measurements on the fetus. And it wasn't related to prematurity, it was related to birth weight. So when we're following these patients with suspected growth restriction, you know, the newer guidelines say, oh, as long as the Dopplers are good and the fluid's good, just deliver them at term. And that's what we do now, and that seems to translate into at least good immediate outcomes. But we don't really know for sure what happens to these kids later, because it's a new type of management. In the past, when we had moms with growth restriction, they were like 35 weeks, 36 weeks. We were just looking for a reason to get them delivered because we were afraid that something would happen to them. And if there's changes in the fetal circulation, I'm sure you guys follow some of those Doppler studies in a baby. So when a baby's growth restricted, the baby's circulation adjusts to protect the brain. So it shunts blood away from the gut and tries to keep it going to the brain to protect the nervous system. So abdominal circumference on the fetus predicts cholesterol and fibrogen levels. So when the baby's developing in utero, Mom eats the foods. We just heard some nice stuff about nutrition. The mom ingests the food, goes into her circulation, goes to the placenta. From the placenta, it goes to the baby. If the baby's getting enough nutrition, the baby saves the glucose in the liver is a normal size. When moms get too much sugar, if the mom's an uncontrolled diabetic because they didn't listen to Veronica's dietary adjustments, then the liver gets bigger, and then the abdominal circumference gets bigger. That's why sometimes diabetic moms have fetuses that have a big abdominal circumference, and those are the ones that we worry about shoulder dystocia. On the flip side, when there's growth restrictions secondary to uteroplacental insufficiency, you're not getting enough nutrition going to the baby. So what happens is less of it is stored in the liver, so the liver now gets smaller, and that translates into a smaller abdominal circumference. If the liver is smaller, it also has a less of an ability to manufacture cholesterol and produce some of the clotting factors in the fetus. So in a growth-restricted fetus, the liver is smaller, and that's secondary to the redistribution of blood flow, the so-called brain-sparing effects that we were just talking about. So there's different types of growth restriction. There's symmetrical and asymmetrical. And the way I like to think of it is symmetrical is secondary, unless it's a genetic cause. If it's, that's a little bit different, but I'm going to talk about environmental exposures or infections and things of that nature. If you think about it, if the fetus gets exposed to an adverse event, it disrupts the number of cells that are dividing. So symmetrically, from head to toe, it has fewer cells, so it's a little smaller. That's not really what happens, but that's an easy way to remember it. So with asymmetric growth restriction, that's where the head circumference is normal size or closer to normal size, and the abdominal circumference is small, and that's more associated with impaired uteroplacental circulation or nutrient deficiency. And it's basically an adaptation of the fetus to an unfavorable environment. So these are the things that growth restriction are associated with as far as adult onset disease: hypertension, heart disease, diabetes, stroke, high cholesterol, thrombotic events, and also impaired neurodevelopmental problems. So when we talk to our patients about growth restriction, we should discuss a little bit of the possible ramifications for the baby as it gets older. And this is information that the internal medicine people and also the pediatricians should be aware of. Some of these things are more acute, some of them take longer to develop. These are some of the possible associations, and I'm not sure, like chronic lung disease, more behavioral disorders, and also some types of cancer. So there's this thing called the thrifty phenotype hypothesis, which basically states that poor fetal growth and development of type 2 diabetes and metabolic syndrome may result from the effects of a poor intrauterine nutrition and permanent changes in the glucose-insulin metabolism. So less insulin secretion and increased peripheral insulin resistance to increase glucose levels. So if you think about it, you have a growth-restricted baby. It's not getting enough food or glucose. So what it does is it adapts its endocrine axis and its receptors to increase the amount of glucose going to the brain. So it shuts down the peripheral receptors and tries to protect the neurologic axis of the fetus. So this could be considered fetal programming, where the fetus adapts to adverse environment by optimizing decreased nutrient supply to ensure survival. So there's blood flow redistribution, and there's also production of fetal and placental hormones to help maintain the fetal health. So it's sort of like an adapted mechanism. It's like a starvation mode in utero. So enhanced sensitivity of peripheral tissues to steroids and insulin result in more efficient metabolism to ensure survival. So the baby also increases its levels of steroid production to try to increase the amount of glucose in the in utero environment. After delivery, these nutritional conditions improve, and this efficiency leads to enhanced postnatal growth and fat deposition. So the baby adjusts in utero. It does all these protective mechanisms to enhance the amount of glucose. Then the baby's born. Now it's out of that, I guess, hostile environment. Now the baby starts getting food and eating, and it gets bigger because it hasn't readapted to the new environment, because it's programmed in a starvation mode. And that's where the catch-up growth could be related to metabolic syndrome and mortality from cardiovascular diseases. So babies that are growth restricted have reduced peripheral body fat. The lipids in the peripheral fat cells is reduced, but it's increased in the visceral tissues. So when the catch-up growth occurs, you get centralized fat distribution. So you get increased visceral fat, which I think we know is a precursor for a lot of adult onset diseases. But the baby's programmed to do that now because of its in utero environment. So there's this other discussion about leptin, which is a product of obesity gene. It's a hormone made of 167 amino acids. It increases energy use and reduces fat intake. It affects bone mineral content. And in growth restriction, it's decreased. But after birth, it increases, which may show that there's a leptin resistance, and this may play a role in catch-up growth obesity. There's adiponectin and cytokines. These modulate glucose levels and lipid metabolism in insulin-sensitive tissues. You get the decrease in insulin-resistant states, and it's inversely related to the weight and fat mass. So this dysregulation may be due to a lack of a negative feedback in growth-restricted fetuses. There's also a possible role of cytokines. So tumor necrosis factor and IL-6 sometimes might be elevated in growth-restricted fetuses, and this may be due to chronic hypoxia. Adipose monocytes and macrophages also produce inflammatory cytokines, and the tumor necrosis factors may also cause insulin resistance in muscle, enabling glucose to be used in other vital organs. So these are some of the processes by which the growth-restricted environment may cause internal adaptations to metabolism to maximize glucose utilization in the nutrient-deprived fetus. On the other side, we have the big baby, the large for gestational age baby. And these kids have a higher risk for metabolic syndrome, high blood pressure, diabetes, obesity, PCOS, and cancers. So with maternal undernutrition or protein restriction, this could result in offspring with growth restriction, hypertension, and impaired glucose tolerance. When there's a high-fat diet, these offspring can have impaired glucose metabolism and hypertension as adults. So your nutritional status also plays a role in the development of these conditions with the fetus as they get older. The other variable is the placenta. So, maternal and placental health are both required to not really optimize fetal growth, but to allow the fetus to grow to the size that it should grow to. So we look at all these different tables for growth restriction and macrosomia, and we take these population statistics and we say, oh, this kid's less than the 10th percentile, it's growth restricted. This kid's over 90%, it's macrosomic. Meanwhile, you're in the room with these two parents that are both like 6'4", you know, or on the flip side, you're in the room with two parents that are like 5'1", and their kid, they've had 3 other kids that are all small. The other family had kids that are all big. So you have to use these tables and this information with a grain of salt and apply it to the individual patient. It's very hard to take a population-based growth curve and apply it to an individual because there's just too many variables. But that's what we have, so that's the best that we can do. So for the baby to maximize its growth potential, the mom has to be relatively healthy and the in utero environment has to be relatively good. So if you have a good mother, maternal health, and good placenta, you get the outcome that you should get. If the maternal health is good and there's a placental factor, you may get uteroplacental insufficiency, which may translate into IUGR or growth restriction. On the other side, you may have a perfectly healthy placenta, but the mother has some type of chronic medical condition, which could also lead to growth restriction. And really, there's sort of hybrid conditions where the mom may have some medical conditions that ultimately affects placentation and placental function. So there's a lot of different combinations. The end result is growth restriction. It doesn't really matter what the cause of the growth restriction is because the fetus gets programmed accordingly if it's growth restricted. So the outcomes could still be the same. So the placenta provides nutrition to the fetus. It converts glucose to lactate. It produces glycine. It utilizes glucose and oxygen from the mother's side and will make up any deficits on the baby side. And it transfers, the most important thing is that it transfers oxygen and glucose from the mom to the fetus. But it's just not the mom and the placenta. Now we have to factor in all these other variables. So we talked about nutrition, we talked about the mother's health, we talked about co-founding variables for diabetes, for the mother, high blood pressure, autoimmune problems. In the in utero environment, there may be a low-grade infection, chorioamnionitis, it might be isolated growth restriction, but there's all these other things that we have to factor in too. Is the placenta working well? Is the blood flow to the mom and the placenta okay? Is there any evidence of smoking or any other teratogenic effects? Toxins from the environment, oxygen, whether it's chronic oxygen deprivation, what types of medications she's taking, is she taking any herbal supplements, is she drinking water from a plastic bottle that's been in her car and it's 300 degrees and all the chemicals are leaching out into the water. I mean, there's all these different things that are going on as the baby's developing. And then the other variable is when in the gestation is all this stuff happening? Is it happening early when there's more rapid cell division, or is it happening later? So all these things combined may have an effect on the ultimate outcome for the baby, not only short term, but long term as well. So when the babies are growth restricted, they're considered stressed. That's why growth restricted babies have a lower incidence of respiratory distress syndrome when you control for age with preterm labor babies. So increased levels may be due to either the mom getting steroids, or that we're giving the steroids because we're worried that the baby may deliver early. It could be elevated maternal levels, or there could be a problem with the placental barrier where some of the steroids cross over. So there may be a reduced number of steroid receptors in the hypothalamus, resulting in impaired negative feedback and upregulation. This can result into increased blood pressure and glucose intolerance in the fetus. And then we talked a little bit, I just want to talk a little bit about this concept of epigenetics, which is very interesting. It's defined as the study of hereditary changes in gene expression and function through mechanisms other than those involving changes in the DNA sequence. So the DNA sequence doesn't change, but the environment, age, disease states activate or deactivate genes that are altered by histone acetylation and methylation and DNA methylation. So basically, you have all these, it's like a control, like your circuitry in your house. You have your circuit breakers, and things in the environment, or just because of age, or you may have a chronic disease condition, causes some of these switches to be turned off, and on the flip side, other switches to be turned on. And these changes in gene expression due to the fetal environment may lead to some of these adult onset diseases. And then there's also the role of genetics. So family history is a known risk factor for pretty much everything. High blood pressure, diabetes, heart disease, thyroid disease, obesity, psychiatric disorders. Everything, genetics is almost like plastics in the graduate. It's everything now. Genetics is the new plastics. So, and there's also this intergenerational effect, which was noted during the Dutch famine. Women gave birth to appropriately grown fetuses. These kids grew up, they had kids, and they went on to have growth, they had smaller babies. So adverse effects during your pregnancy may affect the offspring of that pregnancy and also the next generation. So the thought was that these growth-restricted kids may have smaller organs, which may lead to risks of preeclampsia and growth restriction in subsequent pregnancies. And also that the effects of the parents during the famine caused the changes in their metabolism to lead to their problems with their pregnancies. So we look at twins sometimes to get information to help us figure out what's going on with these babies. And twins overall have a lower birth weight than singletons, usually because there's two of them. If you look at growth curves for singletons and compare them to a growth curve for twins, let's say we talked about dizygotic twins. The growth of a singleton and twins is usually very similar until about 30 to 32 weeks. At that point, the twin growth velocity sort of lowers and plateaus a bit, whereas the singleton continues to increase. So, but in twins, heart disease is not increased. If a twin has a growth restriction, if one twin is growth restricted, it has a higher risk of hypertension or diabetes than the appropriately grown twin. So there's many factors that might be involved. We're not really sure. There's a lot of different factors for growth restriction. And then you have to look at the types of twins too. So with dizygotic twins, if one baby's smaller, the other baby's still its own unique entity. With monozygotic twins, they share similar genetic components, but it might be a nutritional factor or a perfusion factor that may affect the development and the programming of the fetus differently. Then we talked about this a little bit before. There's always timing and the environment. So week 1 is implantation. During week 3 to 4, the spine, head, heart, eyes, and limbs develop. During weeks 5 through 7, it's the brain, the nerves, the heart valves, the kidney, and the gut. So the first trimester is when all these things are developing quickly. So insults in the first trimester may have a different impact than environmental insults in the third trimester. Earlier on, there's high metabolic activity. The fetus really hasn't fully matured, so the circulation in the baby isn't able to adapt to changes, so the perfusion is in a marginal status. That's why when you look at intraventricular hemorrhage in babies, there's an area called the germinal matrix in the brain. That's where you get your IVH grades 1 through 4. So the reason that that's such a common event in preterm babies is that there's a lot of cells dividing. The circulation hasn't completely matured, so there's superficial and deep penetrating vessels that provide circulation to that area. And before 32 weeks, the circulatory system hasn't completely matured. So if you have any changes in perfusion or blood flow, you have an area of high metabolic activity. It's a watershed region for perfusion, so it's highly vulnerable. And that's why those kids, preterm kids, have a higher likelihood of having the hemorrhages. After 32 weeks, the circulation is mature, and you don't have the watershed effects. The number of cells dividing is decreased, so there's a lower need for oxygen and glucose. So at that point, if the baby's delivered, there's less likelihood for those events. They can still happen, but they're much less common. Then we talked about this also. During the pregnancy, there's environmental factors, and once again, the timing of the exposures, the duration of the exposures, and the level of the exposure all play into the ultimate effects on the baby. We have chemicals in I'm from New Jersey, so who knows how many chemicals I've been exposed to. But we talked a little bit about plastics. There's radiation, smoke, pollution, pesticides, processed food, additives. There's the stuff that they put on the foods. There's all these new types of fillers that they have in there. So, when we process these things, it has an effect on us, but if you're pregnant, it may also have an effect on the fetus. Then there's maternal factors that might affect the ultimate outcome of the fetus as well. There's maternal weight gain, overall maternal health, nutritional status, and we talked about this a little bit yesterday also about the diets, good versus bad, vitamins, and we stressed iron, folic acid, vitamin D, because we don't want any of these fetuses to get hip fractures. And also DHA, or the omega-3 proteins, might be good. How much fiber they're taking, ultimately how many calories they're taking, their carbohydrate, protein, and fat ratios. We talked about that carbohydrates directly impact glucose levels, so cutting down a little bit on the carbs and increasing proteins a little bit might have a beneficial effect. And then also, after the baby's born, so you have a growth-restricted baby, the most common sense thing would be, oh boy, this kid's small, I want to feed this baby quickly and get this kid back to its normal size. I want catch-up growth. And that's great, but there's better ways of getting catch-up growth. So breastfeeding is probably the best way or most physiologic way to get catch-up growth. Rapid weight gain in the first few weeks of life is associated with hypertension and obesity, but it's more associated with formula, supplementation. So everyone's trying to get these kids to gain weight, so they're giving all types of food. Sometimes breastfeeding is a little harder. Sometimes the kids are in the NICU, so there's a lot of variables. And that's where this baby-friendly initiative sometimes helps with these outcomes also. Are your hospitals baby friendly? Do you guys know what baby friendly is? Or okay, yeah, we're baby friendly. You know, I don't really like that term, baby friendly. I just have to take a sidebar. So before we were baby friendly, did that mean that we were baby unfriendly? Because we were. So anyway, so we're a baby friendly hospital also, but it's a great initiative. Basically, it involves education and promotion of breastfeeding. So long term, that's probably a good thing if the patients are able to do it. And the other question is, this baby's programmed in utero. Is there any way to turn some of the switches off that should be turned off and turn some of the switches on that should be turned on? So there's some evidence to suggest that some of these effects may be reversible. In animal studies, there's a suggestion that supplementation of leptin may reverse the physiologic changes caused by the malnutrition in utero. So there's ongoing research to see if we can sort of reverse some of these adverse in utero effects. And then the big question is, can we really help? And I have to say, yes, maybe, because I think it's got to be a relationship between the physician and the patient. The patients have to be motivated. The best time to do a lot of this counseling is before they're pregnant. So at the well woman visits, maybe when you're discussing contraception, there should also be a discussion possibly about preconceptual preparation for for conception. When you're putting people on contraception, they're always trying to avoid getting pregnant, which is good. But at some point, they may choose to become pregnant, so it's not a bad time to give them some of the information. We can reduce some of the exposures that we know are harmful to the fetus, possibly reducing alcohol exposures, smoking cessation, or even reducing the amount of tobacco use. For patients with chronic medical conditions, there might be the opportunity to adjust medications to make them possibly more favorable for pregnancy. We can talk about nutrition to make sure, or at least educate them on what they should be doing and try to give them support to actually do it. As we heard before, these have to be like lifestyle changes. It's like short-term dieting and adjustments help for short-term, but it's really got to be a commitment to a lifelong change. Having adequate vitamins, folic acid, vitamin D, iron, possibly omega-3s, might also be something that can help. Depending on the situation, some weight loss might be beneficial, or possibly even weight gain. Early prenatal care is also helpful because, when you look at the timing of prenatal care, there's not that much difference between early, mid, or late prenatal care. The big thing is prenatal care is a categorical value, yes or no. When you look at prenatal care, people who have some prenatal care have better outcomes than people with no prenatal care. But if you're looking at trying to maximize the possible outcome for the mother and the baby, earlier preconceptual care or early care, prenatal care, gives you an opportunity to educate the patients earlier in the journey, because we talked about the timing of exposure, the length of the exposure. So this might be your chance to have an impact. Also, in patients who have a history of preeclampsia with a previous pregnancy, it might be an opportunity to counsel them about aspirin supplementation, 81 milligram aspirin supplementation, and calcium supplementation. There's some evidence to suggest that starting these therapies early in the first trimester or before 16 weeks may improve the placental function in these patients and also reduce the risks of recurrent preeclampsia. Early in pregnancy is also a chance for you to start promoting the benefits of breastfeeding. So the patients are better educated, so when it's time for them to actually have the baby, they have a better understanding of the possible benefits to breastfeeding and hopefully are willing to give it a try. So we think that the in vitro environment impacts adult development, which is determined by maternal, placental, fetal, and even environmental factors. Growth restriction is associated with adult onset diseases, including high blood pressure, heart disease, diabetes, stroke, and high cholesterol. LGA infants also have increased risk for metabolic syndrome, high blood pressure, PCOS, diabetes, and cancer. Thank you very much. This is a sunset in New Jersey. Not as nice as here, but not so bad.